Good morning, students. Today we will be studying about Parkinson's disease. In the previous video, we tried to define the disease, and we understood that it is a neurodegenerative condition and where there is loss or decrease in the dopamine production, and the reason was the subcortical nuclei of the basal ganglia, all the nuclei, in which specifically, if I can say, it was substantia nigra par compacta which was been affected. And then we studied about how it is affecting the movement. We studied the direct and indirect pathway and how this is basal ganglia is responsible for initiation of movement and how it has been affected in movement. So we discussed about the clinical symptoms like the presentation of akinesia, bradykinesia, tremors, rigidity and postural instability. And we also studied about the terms called Parkinsonism and its categorization, and we emphasized on the fact that this was just an introduction, but we emphasized on basically understanding the basic disease itself. Now in this video we will be going for clinical point of view, that is PT rehabilitation point of view. What we can do, what we should evaluate in this condition, how we evaluate certain points and how we go in for a rehabilitation. Fine. So let us define this. Parkinson's disease is a chronic progressive disease of nervous system characterized by cardinal features of rigidity, bradykinesia, tremor and postural instability. Rigidity is stiffness of movement. I will be taking in detail of all these features properly. Fine. And bradykinesia is slowness of movement. Tremors is, there will be in resting tremors, spin rolling tremors, and postural instability, balance and is affected. Now we have already seen that basal ganglia plays a very important role in inhibiting specific motor synergies, and it plays also a very crucial role in cognitive processes. Basically the caudate nucleus, it helps us to give an awareness of body orientation in space, whether we are standing straight or we are deviated. This orientation is also given by the caudate nucleus. When we have to turn, when we are on a two-wheeler and we have to turn, so the orientation that my handle has gone to the other side and my body also rotates to the same side, this orientation or the awareness of a body in space is given by the caudate nucleus. Fine. And how we change our behavior according to this is our cognitive processes, that is our thinking power. Fine. This function is done by basal ganglia. We have already done this in detail, but to just we will read through this. This is the figure of basal ganglia, the putamen, the stratum and caudate nucleus and all the parts, other parts. The input is taken by the basal ganglia, that is the corpus stratum, and the input is received from all the cerebral cortex and substantia nigra par compacta, and output goes through globus pallidus and the substantia nigra par reticula towards the thalamus and then back to the cortex. Fine. Now epidemiology. Epidemiology is basically a branch in medical science which deals with how the disease is present in the typical community or typical area. The study of the disease, how the disease is progressing or how the disease came and how it is progressing in a particular area or a particular community is called epidemiology. Like in India, like in Parkinson's, we know that it was been coined by by James Parkinson, and he coined this disease as shaking palsy, but he coined this as shaking palsy thousands of years ago in London. But in India, how this prevalence is there, how much how many Parkinson's case we can see. It is called as epidemiology in India, epidemiology of Parkinson's disease in India. In India, the crude age adjusted prevalence rate of Parkinson's disease per lakh population is 14th in North India, 27th in South India, 16 in East India, and it is found that in Parsi community, it is the incidence is more, where we can see there are 363 people per lakh population of in Mumbai. Fine. So this is how the epidemiology can be written. Etiology I have already discussed, but let us go through it. Parkinsonism, it is a clinical syndrome or a group of disorder that produce abnormalities of basal ganglia function. The Parkinsonism can be divided as idiopathic Parkinsonism or primary Parkinsonism, secondary Parkinsonism, which is because of a vascular cause or a drug induced Parkinsonism, and Parkinsonism plus syndrome. Now this is atypical Parkinsonism, where the condition that mimic like Parkinson's disease but have got other neurodegenerative disorders also, like dementia with Lewy body, which we discussed in the previous video. Fine. Now this is a more a pictorial depiction of what happens in Parkinson's disease. You can see there is degeneration of dopaminergic neurons that produce dopamine, and there is also loss of melanin containing neurons, which are results in depigmentation. There is formation of Lewy bodies, which can be seen in the brain, that is deposition of abnormal protein in the brain, and there is loss of dopamine, which results in, you know that, rigidity, akinesia and bradykinesia. Now you can see how it is affected. It is affected in the right upper diagram. You can see how the movement disorder takes place, how the normal movement takes place, and how because of lack of dopamine this signal cannot be transmitted. Fine. Through a synapse it's very difficult to transfer the signals. Why so? Because dopamine is not properly released, so the movement is not transferred. So these are the all nuclei which are there. Fine. So now this is the important part which I wanted to discuss in this video, was the clinical presentation. Now clinical presentation is the first thing is which we see in this is rigidity. Now here you see the image of a person. He is showing the neck rigidity. The rigidity is so much that the person is not able to lie properly on bed. Why so? Because the flexors as well as the extensors, they are getting contracted at the same time. They are not relaxing at all. Rigidity is what? It is increased resistance to passive movement. Resistance to passive movement, and at the same time the agonist, that is the flexors of the neck and the extensors of the neck, contract, and when they contract it will be very difficult for the person to relax. Fine. So it is of two types which we see is cogwheel type and lead pipe type. Now cogwheel type is like a jerky movement, resistance to passive movements, where there is a tense movement and a relaxed movement. That is there will be a jerky movement, yes, then jerky movement and this jerky movement and relax, jerky movement and relax. You can see it is it will initially there is a resistance, and then when the muscle will contract you can move, passively move the arm, then there will be a resistance, and then again you can move the arm, then there will be a resistance, and again you can move the arm. That is cogwheel type of a rigidity. Whereas lead pipe kind of a rigidity is when you will find resistance, it will be very difficult to move throughout the range of motion, the arm. This will be difficult. I will find resistance throughout the range of motion. There will be no relaxation. So this is called as no fluctuation of tone will be there. This is called a lead pipe kind of a rigidity. Now if this rigidity prolongs for a long period of time or is there for a long period of time, it decreases the range of motion of a particular joints, and then there can be contractures development, and there is postural deformity which can happen. So you can see there is neck rigidity is very much common, and this is a clinical hallmark of Parkinson's disease. Rigidity, that is increase in tone of agonist and antagonist. Tone is the resistance to passive movement. Tone is normal tone. What is normal tone? The resistance which or the increase in tension which we feel when we move an arm passively is called as the tone. This is the normal tone, and increase in tone we say when we find a good resistance to the normal passive movement, that is called as increased tone. Now in this increased tone, the tone increased is of agonist muscle as well as antagonist muscles. Fine. Both at the same time the tone is increased. The second thing is bradykinesia. Bradykinesia is slow movement. That is, kinesia is movement and bradykinesia is slowness of movement. There are 2-3 terms also related to it, like akinesia, it is absence of movement. Hypokinesia is decrease amplitude of movement. Fine. So, and there is another term called freezing of movement. The person is moving and suddenly he doesn't know what to do. Like if the person is walking on a corridor and suddenly he has to take right turn, he will walk through the corridor and then suddenly freeze for a period of 5 minutes because he cannot make a turn on the right side. So that is called as freezing episodes. This is because of bradykinesia. Fine. So and then there will be reduced, you can see the movement speed, range, amplitude will decrease. If the person is walking, the speed, the stride length will reduce, their hip range of motion, the knee range of motion will reduce, and of course the hip flexion will also decrease. So there will be basically depression in movement, or there will be slowness and difficulty in doing that movement. This is the characteristic sign of bradykinesia. You can bradykinesia, akinesia, hypokinesia, or freezing episodes. These all terminology come under the same heading, like slowness of movement or absence of movement. The third sign, which is very much important, is tremors. Now let us first define tremor. Tremor is involuntary oscillation. This is also a tremor. Involuntary oscillation of the body part with a slow frequency of 4 to 6 hertz. Fine. So herein we find that the person is involuntarily in resting movement. Resting tremor is there. It disappears as soon as the person tries to pick up a stuff. Okay, as soon he is doing any voluntary movement, this tremor goes off. Okay, this is spin rolling tremor. This is called a spin rolling tremor. Then this tremor can also happen in the supination and pronation tremor at the level of forearm, or clenching and of jaw. This can happen, or the tongue. So these are the movements. Resting tremors can happen in the forearm also, jaw, tongue, or in the fingers, spin rolling tremors. It can happen even in lower limb when the patient is supine. Herein you will find the person may have tremors in the lower limb also, that is in the foot. It can be there, and it can also happen in any upright position whenever the person is trying to maintain an upright position, like in sitting. If he is sitting for a long period of time against gravity, of course when we sit against gravity, and then there will be head and trunk tremors will be present. So these tremors completely diminish during sleep. Next is the postural instability. Now this postural instability, this is because what happens is because of the posture, as we have discussed it earlier, the person is leaning forward. There is a stoop posture has become. Okay, the chin is forward, then the shoulder are rolled, then elbow is flexed, and the arm swing is reduced, where you can see the pelvis is moving posteriorly, and because of the posterior tilt of the pelvis, the hip flexors are tight and knee bends, and there is plantar flexion at the foot. So this all results in a decrease in the center of mass, that is decrease of the height of the center of the mass. The center of the mass of the body lies at S2 vertebra. And herein what happens is that it falls, it raises far ahead. So in order to bring it back to S2 vertebra, the person starts leaning further forward and starts having short stepping gait. So this is also called as shuffling gait or short stepping gaits. The stride length of the person decreases. He takes a very small steps in order to bring the center of mass back to S2 vertebra. Why so? Now the center of the base of support of the foot is narrow, and herein he tries to find his own balance. So if he is not able to find it, what we will do, we will try to take steps quickly. So it is shuffling gait. Why? Short stepping and shuffling gait is there. Fine. So these are the changes which happens. We will be discussing about gait in another slide, but herein we see there is postural changes which are happening. This is all because of rigidity, because of the decrease in muscle range of motion and a decrease in truncal motion. The posture changes, and there is weakness of extensor group of muscles, as well as the flexion posture or stoop posture is also responsible for all this kind of postural instability. Fine. Now you can see this gait, and you can see the frontal view and the lateral view of the person. You can see how much he is stooped forward and how he is taking steps. Now he's as if when he's taking short shuffling steps, you will see from the lateral view that he is trying to catch his own center of gravity, or he's trying to prevent himself from falling. So he will try to do is, he will first calculate that I have to go move this much, and as soon as I reach over there, I'll grab something. So he will take short stepping gait and try to grab stuff. This kind of a gait is called as fascinating gait. Fascinating gait. It is shuffling. Short stepping gait is called as fascinating gait, and it increases, the speed increases since the step length is small but the speed is more. It can be antropulsive or retropulsive. What does this mean? The person can walk forward as well as walk backward. So in this condition we find both, like the person is moving forward as well as the person is moving backward, and it is very difficult for the person to stop in between, because then there is also freezing movements, and if he is freezed upon movement, he will fall. So it is very difficult for him to maintain this gait also. Fine. Now what other things is motor planning and motor learning. Now you can understand the cognitive decline. There is a cognitive function is affected in this disease. So what problems you will find, what the patient will say to us. The patient will or the attendant who comes to us will say that he is feeling very much he is very much hesitant to start a job with simple normal day-to-day task. He is very slow to start with a job, or he is very hesitant to start a new job. Okay? And he will say that it is very difficult whatever he is writing. It's very difficult when he is speaking also, but it is very difficult for him to we all guys to understand what he is writing. That's called as micrographia is there. Fine. Small handwriting. You can see the image. I've tried to add a image over here, but see, it is the first letter is visible, and then it is very difficult to see. Then there is also poverty of movement. This is called as hypomimia, and this movement is also on the face. The person becomes has an expressionless face. Now when we are communicating with one another, we use facial muscles to express ourselves, to express sorrow, express happiness, but herein the person is not able to give any facial expression while communicating. So this is there. The person also has learning deficits. He cannot, if he is given any procedure to follow a process, this has procedural learning deficits. He will not be able to do anything in proper stepwise. Fine. So these are the problem which in motor learning is he is having. The next point is sensation. There is, remember, in Parkinson's disease there is no primary sensory loss. It is totally a motor condition. Fine, there is no sensory loss, but sometimes the patient complains of that he is having numbness, paresthesias are all there. This is because of the posture. It is not related to the primary or the sensory cortex or the primary sensory loss. It is just because of the postural stress syndrome. Because of the faulty posture, because of this rigidity, he may experience there is some kind of a numbness and tingling or cold aching sensations. Fine. And speech, voice and swallowing. The person will complain of that I find very difficult. I choke a lot. Whenever I drink water, I choke. I have to cough. There is activation of cough reflexes there. So this is because again there is rigidity of the swallowing muscles is there because of the lack of mobility and restricted range of motion, and there is again choking episodes are more. If it is more throughout the day, the chances of getting aspiration pneumonia is also more. But the second effect is that there will be lack of nutrition. The person will stop taking food because he knows he will choke. So these people, they then suffer from weight loss, they suffer from lack of nutrition, and they because of that lack of nutrition, they suffer from exhaustion or fatigue. So whenever we go in for assessment of the person, we also go in for Berg's area. There is a scale of exhaustion. The scale properly, we evaluate the condition of the person according to that scale. We will discuss this later on, but herein you should understand first that because of this lack of nutrition, the person is having fatigue. Now, second point is he will be having, he is not able to swallow, and the second is there is an excess of saliva formation, and because of that he is not able to swallow, so there will be drooling will be there. There will be excessive drooling also there. Now the next part is he will be having hypokinetic dysarthria. Now what is this term means? Now this is related to our vocal cords, and they are responsible for the kind of hoarseness of voice, or they are responsible for the pitch, how high we can, how variation of tone we can take. Sometimes we need to stress upon certain things, so we increase our tone and increase our pitch, and whereas sometimes we give a normal, when we read a stuff we read normally, so there is variation of the tone and variation of the we can say hoarseness of voice, the rate at which we speak. This all is being controlled over here, so there will be decrease in the mobility of or hypokinetic dysarthria, decrease in the because of the decrease in the motion, the person will have a mono pitch speech. Mono pitch is he will be monotonously like reading a newspaper. Nutritional inadequacy contributes to fatigue and exhaustion. Presence of siluria, excessive drooling, as there is no increase in salivary production and increased swallowing. So he will be continuously reading in the same pitch and everything, as if he is reading a news, but it will be very difficult for him to maintain this variation of tone and the volume of voice, variation in the pitch of the voice. It will be very difficult for him to do. And why it is also this is also because of the respiration, because our respiration also plays a very important role. So sometimes in phonations we need to whenever we need to stress on certain words, we use our breathing. So since our muscles or the range of chest mobility is also reduced, so we find that the phonation, respiration and articulation, there is some difficulty and there is decrease in motion. So what happens is that because of all this, the person stops communicating. Why so? Because the second person who is on the other side, with whom we are communicating, is not able to understand what you are saying. So in that case, in advanced stages, the patients demonstrate mutism. Fine. The next thing is autonomic nervous system. Now this is very important. You understand autonomic nervous system is for our fight and flight response. It has got sympathetic and parasympathetic system. Sympathetic is responsible for constriction of pupil, increasing the heart rate, palpitations, there will be sweating, and constriction of GIT tract, constriction of urinary bladders, fine, and increase in the heart rate, cardiac output, sweating activities, they will be increased. So whereas parasympathetic is responsible for vasodilatation, pupillary dilatations, and relaxation of again normalization of BP and respiratory rate, and it will bring about relaxation at the level of digestive system and other systems. So you can understand one is for the constriction and another is for dilatation. So there is abnormality in autonomic nervous system. Now what will happen in this condition is there will be thermoregulatory dysfunction. What is that? There will be excessive sweating and there will be abnormal sensation of warmth or coldness will be there. Fine. So this is the thermoregulatory that dysfunction will happen. There will be seborrhea and seborrheic dermatitis. Because of this excessive sweating, there will be hair, there will be dermatitis, there will be itching around the skin, and there will be also slow pupillary response to light and pain. So I told you there is constriction of the pupil as well as dilatation of the pupil, so there will be a response of pupil to light and pain will decrease in this. Regarding GIT tract, there will be dysfunction of GIT tract also. There will be poor mobility, lack, changes in appetite, celuria, constipation and weight loss will be there. And regarding urinary bladder dysfunctions, you will find urinary urgency, frequency, incontinence and nocturia will be very much common, and even sexual dysfunction is also present. So this all is because of autonomic nervous system. Cognitive function and behavior. We have already touched this part, but let us just read through this. Dementia is common in 20 to 40% of Parkinson's disease patients, where there is loss of executive functions of planning, reasoning, abstract thinking, judgment, change in visuospatial skills, memory, and verbal fluency, that is a formation of sentences. Fine. So it will be visuospatial is trying to draw whatever you see. We can draw this diagram, so it will be very difficult for them to draw the diagram. Reasoning and abstract thinking, mathematical calculations and everything. So we have already discussed this executive functions. Fine. There will be bradyphrenia, that is disorders of intellectual functions, that is there will be slowness of thought and information processing. Whenever we are trying to discuss about certain important topic, there will be difficult for them to process the information. Fine. And they will have also a problem called selective attention and in shifting attention. Now in this Parkinson's, there was a study which was been done, and it was found that they find it very difficult to concentrate on 2 or 3 tasks at the same time. Whenever we are working, we hardly work, we concentrate on one thing. Whenever we are doing, or we are also working on our mobile, we can take a call simultaneously, we can write simultaneously, even we can communicate with others simultaneously. So we can do 3 or 4 tasks at the same time. This is called triple tasking or dual tasking. But what we find over here is that because of this shifting attention, they are not able to maintain concentration, or they cannot do 2 tasks at the same time. So if they are walking, they will only walk, they cannot take a call side by side. So they will try to do one thing at a time. They cannot do 2 things at a time. So there is hallucination and delusions are really common over here, and depression. Because of this, later on, and when the stage 4 and 5 happens, till that time the person starts suffering with depression. Cardiopulmonary function. Now again, the cardiac function is also been affected, that is orthostatic hypotension, decrease in there is a BP, lowering of resting blood pressure is there, cardiac arrhythmias, increase in heart rate, airway obstructions because of pneumonias we have seen, restricted lung diseases, the chances of lack of chest expansion. So when there is lack of chest expansion, when spirometry, there is a test of for assessing the chest function which is called a spirometry, and in that we see that there is lower forced vital capacity, the capacity of the lung. We try to check these values, and it decreases in Parkinson's disease. Forced expiratory volume also is decreased, and the residual volume, that is the amount of air which is left in the lungs after we go in for inspiration and expiration, is called as the residual volume, that is also reduced. Fine. So there is again important thing is venous pooling of in lower extremity, that is pedal edema, that is because of decrease in mobility of the lower limb of long sitting, there is pedal edema at the level of lower limb, that is foot is swelled. Fine. So this is there. So this was in detail about the clinical presentation of the Parkinson's patient. So how do we as a medical make a diagnosis out of it? So we have to go in for a detailed history taking of the person, and once this history taking of the person is done, then we go in for a clinical examination. Now clinical examination include the speech examination, handwriting examination, interview questions and everything. And then how do we make a diagnosis is, if out of 4 cardinal points, 2 cardinal points are present, we have to go and take a we make sure that we have to go in for other clinical diagnosis, or we should be alert enough that this may be a condition of Parkinson's disease. Fine. So a diagnosis of Parkinson's can be made if it is at least 2 of the 4 cardinal features are present. Fine. So for rehabilitation also, we have to make sure that a pharmacological intervention is a key role, because this will help in reducing the rigidity. Then because muscle relaxants need to be given to this patient, because they need to be, or dopamine substitutes, levodopa need to be given to the person, so that movements are more easily done. And on that base, we can help them to be more aware of, or more helpful. We can help them or assist them in doing day-to-day activities. So physical therapists play a very crucial role in maintaining a person's physical mobility, so that he can maintain his whole day-to-day activities. ADLs, we say it as activities of daily living. Now we take patient examination, how a PT evaluates, or how a PT frames his treatment protocol is. We have to go in for a detailed patient examination. Then of course his neuromuscular examination, musculoskeletal examination. Neuromuscular is basically we go in for a mini mental state examination of the person, and we state whether how much if the person is cognitively inclined or declined, we come to know. It is mini mental state examination is taken out of 30. If it is less than 23, we declare it as cognitively declined. Fine. And then we also go in for cranial nerve examination, and all the cranial nerves and facial nerves especially, will come to know that the facial nerves, they are not able to move their facial muscles. So this examination can help, is helpful over there. Then we try to see is musculoskeletal examination. Musculoskeletal examination herein means the tone, the muscles. We first see the tone of the patient and of the muscles, and then we see whether it's a rigid increase in tone is there. Then we have to find out whether it is one spasticity is there or rigidity is there. So if both the side the resistance we find, then we say it's a rigidity. And then we try to see the range of motion of each and every posture, gait, range of motion of each and every joint. They need to be examined. Examination should be done. Pulmonary and cardiovascular examination is chest expansions need to be taken. Spirometry, through spirometry we can have to take the lung capacities and lung volumes. We need to check all those, and of course heart rate and BP need to be checked. And other symptoms, like if you're having bladder problem, we have to check on the bladder condition also. For a GID problem, we need to examine according to the patient's symptoms. Fine. So these are the in detail we have to take. And what we do over here is we make an assessment. After doing all this examination, we have we assess the disability of the patient, whether in which stage this patient disability is. Like the stage 1 is mild or early disease, in which only one side of the body is affected, and that is a tremor will be there. Only one symptom is there, and there is no other symptoms, only tremors, resting tremors are there. In stage 2, which is again said to be the moderate stage, here you will see that there will be both side of the body is affected, but still the posture and balance is not affected. Both side of the body the tremor is there, but the posture has not been affected. In grade 3, both sides of the body along with the posture and balance is affected. So we say it as moderate disease. Grade 1 and grade 2 is in mild or early disease. Grade 3 is the moderate disease, and grade 4 and 5 is the advanced stages of the disease, where both sides is affected. Then there is disability in standing and walking, and the patient requires help and cannot live alone. Fine. And in grade 5, the patient is in severe stage, where the patient has to take a wheelchair and is fully dependent on other person for his day-to-day activities. So with a detailed assessment, we come to know what stage of Parkinson's disease it is there. So our rehabilitation totally depends upon this. Now physical therapy intervention. Now what all techniques we have. Like depending upon the stage of the person, the therapist will make his own exercise plan. Herein I am just telling you the techniques which we use. You have to write your exercise plan yourself, but here I will be telling you all the techniques and all the programs which we apply on Parkinson's condition, like motor learning strategies. Now what we need to tell him is, one, there is fatigue. The person is having fatigue. There's a depression to the person is there, and he has freezing episodes. So what we try to do is, one is we have to give him visual cues. What is, we have to give him checkpoints. You have to just walk to that point, and then very good, you are taking good steps. Auditory cues. Okay, you can take your own time. You have to give rhythmic auditory stimulation, auditory cues, visual cues, so that it facilitates that he has to do this task. Or you have to give a structural instructions, that is structured instructionals should be given to them. That is step by step you need to give a command to the person, so that he practice this step by step, and you can give it in through audio tapes also, so that he repeat this day-to-day activity. For example, if the person has to take water in, he has to drink water, he will lift a bottle from the fridge, unscrew the lid of the bottle, and then pour it in a glass, and then take the glass and drink. This requires steps. So you need to give instructions accordingly. You need to get up, go to the fridge, Fine. Then open the fridge, pick the bottle from both hands, close the fridge, then pick the glass and come to the table, sit on the table, put the glass and the bottle on the table. Now unscrew the bottle, lift the bottle, pour water in the glass, and then lift the glass with both hands and take it to your mouth and start drinking. So this whole is divided into 10 to 12 steps. You can see this is divided in 10. So you need to give this structural instruction sets to the patient, and he has to practice this for all the day-to-day activities he's doing. Fine. So he need to repeat it again and again and again. This is called as motor learning strategies. Fine. I've given you one example. You can frame all the examples according to the requirement of the patient. Then is relaxation exercise. We have seen that the patient is fatigued, the patient feel exhausted. Why so? Because of the rigidity. So you have to give him gentle rocking movements. Fine. If movements are not possible, a chair can be used for relaxation. You have to go in for relaxation tapes. So he made breathing exercise, shavasanas, or inhaling, exhaling to slow down, or chest relaxation exercises, or leaning on the wall exercises and deep breathing. And of course, lifestyle modification. Now he should understand that he cannot take so many things at the same time. So he need to prioritize things. So he need to write down on a piece of paper what he has to do to it today. Everyday plan should be made, and according to that he need to stick to those plans and try to cover the whole day. If he tries to do so many multitasking in one day, he will be finding it difficult to do. So he will be exhausted, he will have fatigue. So lifestyle modification is a must. Decluttering is a must. The house should be neat and clean. There should not be obstacles in the house. Unnecessary things should be kept away. Fine. Flexibility is important. Now this is an important thing, because we understand that because of the rigidity, the range of motion is restricted. There is poverty of movement. So emphasis should be made on stretching exercises, range of motion exercises, mild stretching and range of motion exercises, so that the posture is improved, so that we can increase the posture. The next thing is the cardiopulmonary training. The cardiopulmonary training is, again, you understand the chest mobility is very much important. So what we do is breathing exercise, which we say it as active cycle of breathing exercise. We teach them how to hold breath, how to breathe, hold breath and release, and complete the cycle. And second is huffing and coughing technique, because aspiration is or choking is very common. So how to huff, how to cough, techniques are being taught. Along with that, chest mobility exercises are taught. Fine. So that diaphragmatic breathing, then again intercostal breathing, all these techniques are being taught. Fine. Emphasis should also be given to group and home exercises. Now what are group exercises? Because there is lack of social interaction among these people. So if possible, 2 or 3 people who are having Parkinson should be given same timing, so that you can start with the group exercises. Like flexibility exercises are simple exercises, or deep breathing exercises are simple exercises which you can give in a group also. And with this, what happens is they interact with one another and they see how the other is coping up. So what problems the others are facing and how they are coping up. They are interacting, they are also finding, it boosts their confidence. And this kind of interaction should be more often done. Like group exercises should be done. Fine. Next is balance exercises, and this is very much important. Now balance exercises is exercises it should be like stepping, marching at a place, and reaching forward to pick an object, heel raise, toe offs, or partial wall squats, chair raises, single lip stands, side kicks, back kicks. These all exercises which we do, kitchen sink exercises, sitting activity exercises, they are all balance exercises which we need to give. Now another thing is functional activities need to be encouraged. Now what are functional activities that need to be done is they need to go in for truncal movements. Now these movements are very much required. Rotational movements need to be required, and for balance, as well as they need to be done in on the parallel bar, so that truncal rotation, picking a ball, catch and throw of ball, kicking of a ball should be done, so that truncal movement is there, and we work on a close kinematic chain. Fine. And strength training is also there, that is sufficient. You can use for the weakened muscles, for as the posture is involved, so you can use all those the muscles which have been affected. Strengthening exercise, mild strengthening exercise can be encouraged. Functional training, now these people, they find very difficult to sit or stand or to move. They find it very difficult to do, so you need to go in for mat exercises with them. So that exercises are called as functional training exercises, like how to move on bed, size, lying, side lying, supine, prone, rolling, then side lying to sitting, sit to stand, stand to reach forward. Facial exercises need to be encouraged. Correct sitting posture need to be encouraged. Correct eating posture need to be encouraged. Correct bridging and shoulder mobility. Shoulder girdle and pelvic girdle is very much important, because in stoop posture the shoulder girdle and the pelvic girdle is affected, so the mobility of shoulder mobility and pelvic mobility is required. Fine. And again, breath control exercises while doing these transition exercises are emphasized. I hope you have I have tried to cover all the PT aspects, PT techniques which we use in Parkinson's disease, and I hope you have understood the condition, the clinical condition of the person, as well as patient, as well as the what all rehabilitation tools we have, so that we can help this kind of a patients. Thank you guys.